Good evening, everybody. We are about to start in just a moment. Just some few housekeeping details. If you have joined the call by phone, please be sure to email me, Angela Vasquez, at angela.vasquez@conehealth.com with your contact information so that we are sure to capture everybody who's joined us tonight. All participants are muted upon entry. If you have any questions, please type them in the chat box at any time, and we will address them at the end of our presentation during our Q&A time. At this time, I'm going to turn it over to Dr. Beth Hodges. Dr. Hodges?
Dr. Hodges, can you hear us?
Good evening, everybody. Thank you for joining us tonight for the Combined Primary and Specialty Care THN Division meeting. Thanks for joining us this evening. We're going to have a pretty brief meeting tonight because we know it's mid-December and you all are very busy and we want to be respectful of your time, but we did feel that it's important to update you on what's going on. We're getting lots of questions on where is VBCI, what's happening, and we felt important to make sure everybody is on the same footing in terms of knowledge. You're going to hear a lot tonight about VBCI and how VBCI and THN are partnering in our commitment to support your practices. The deal with Cone and Risant is finalized. Now we are part of Risant Health. And if you missed any of those town halls after the signing, a recording plus an email frequently asked questions form was mailed out this week. So be sure to check that out. It's good information. THN currently has 5 physician liaisons, and we will be expanding very soon in the next couple months to 6 full-time physician liaisons. Specialty groups will be informed of their new assigned liaison after the first of the year, and that liaison is your direct link to THN. And of course, you can always reach out to me, you can reach out to Julie, you can reach out to any of us, but your liaison should be your immediate point of contact if you need anything. And that goes for PCPs and specialists. I want to remind you that THN is a partnership between specialists and PCPs, and that partnership is critical to the success of our network. THN can only be successful if we work together to control the total cost of care. And now I'm going to introduce Danielle Phelps-Swartz. She is the Vice President of Population Health and Value-Based Care, and she's going to tell you all about the really exciting things that VBCI is doing. Take it away, Danielle.
Thank you, Dr. Hodges. Can everybody hear me okay? Great. I'm going to share my screen. Again, like Dr. Hodges said,
Danielle, we cannot hear you. Hold on.
Oh.
I don't know why. I need somebody with more technical expertise to fix that.
Can you all hear me?
Actually,
I can hear you. I'm hearing you okay.
We hear you.
Hear you fine.
And can you all see my slides?
Yes.
Yes.
Okay, so Beth can't, but we all can.
Yes.
I will text Beth.
Oh, good. Somebody's in her office with her. Good, good, good. All right, so you all can see slides and hear me. Thank you so much, team, for sharing this evening with us. Again, I want to be respectful of your time, but we felt like The VBCI has been around since February of this year, so we're about 10 months in and felt like we owed you all, the providers, a really good update of what have we been doing. So this evening, we're really going to ground ourselves in, again, just some core concepts. What is the VBCI? What are our bodies of work? What have we been doing in 2024? What are we going to do in 2025? And really relate that all to you all, right? So you're caring for patients every day, you're in the trenches. And really, I want to bring you a good picture of what does it mean for how the VBCI and THN can interact with you all. So that's kind of what we're going to roll through. Again, please do not hesitate to throw notes in the chat or questions, and we will absolutely answer those at the end of the discussion. All right, so just making sure that we're all aligned in really what is the VBCI. I think people still say, hey, I don't get what these pieces and parts are. Really, the VBCI is meant to be a catalyst, a body of work that helps drive and energize the network around value-based care, right? So we wake up every day and our job is to really be focused on operations, thought leadership, data and tech, and bring all these pieces to life to you in your practice. We've been busy for the last 10 months really kind of working on the infrastructure for that. And so I'm excited to share what does that mean when we look at all the pieces and parts, but really meant to embody and help you deliver work across the system of care delivery. So not just where you deliver it, but how do we connect all the pieces and parts that bring it to life in your own practice? So how do we help you know what hospital discharges are happening? And what does it mean from a performance perspective, right? When we think about cost of care. So the VBCI is brought here to help you with all of those pieces and parts. The why do we need to create the VBCI, right? And so when we think about where Cone is headed, right, and on their journey from success in value-based care to being really significant, that's where we really want to see ourselves as a national leader in value-based care. And with the tools that Ryzen is bringing, we know that somebody and departments waking up every day thinking about this are critical to our success. So the VBCI is partnering with the network to be that enablement body to help bring this to life. Critical for how we think about it in specialty and primary care, right? So we wake up really focused on those two lenses every day. This is the infamous network slide, and what it really depicts is how do we ensure that we are working as a single healthcare delivery system. So when we think of a clinically integrated network, when we think of THN, how do we connect all the pieces and parts? What we really want to do is think of the patient at the center. That is the sort of the golden home that's in the middle of that visual. Think of the patient there and how we connect all of the care delivery aspects, right? So the VBCI is really wanting to ensure that we connect all these pieces and parts. There's times when we have to lever or we pull the hospital lever, right? Someone has an acute issue, we pull that lever. Then we have to bring them back to their home or maybe to a nursing home. The VBCI is really trying to focus on how do we do that seamlessly for all of you in the provider space, right? Maybe it's mobile strategies we need to deploy. Our teams are really focused on, well, what does that mean? How do we do that across the system and connect it? That integrated care delivery is always a difficult piece to solve for. That's really what the VBCI is waking up every day trying to think about. All right, how do we do this and bring this to life for our providers? We're going to go over in the next couple slides what do those bodies of work look like? But really what I want you to harness from this visual is this is what we are partnering with the network to do, to bring all these pieces and parts, these synapses together, right? So think of it as a mapping exercise. I think often that's been a big barrier for integrated networks, right? It's hard to pull all that together. That's absolutely the pieces and parts we're thinking about reinforcing for the network. So in order to think about how we do all that mesh, that web, I think it's really critical for you to understand what do these bodies of work look like. I think the question we get asked most is, well, what are the teams? Who are these? Who is the VBCI? So we're going to first talk about what teams exist today, and then sort of lean into, well, what will a future state look like? So I'm going to give you a picture of what we want to build out. I'm giving you a snapshot of these are really some of the core services and programs that exist today in the Value-Based Care Institute. Again, we're going to lean in 2025. I'm going to show you a roadmap of all the things we're working on. But today, this is really what it looks like. So I'm going to quickly run through this because these are the pieces and parts you might historically know of as we moved efforts and teams from THN into the VBCI. These legacy teams still exist. So you may or may not know those teams. They are care management teams run by RNs, social workers, nurse care managers, social workers. It's disease management efforts, often run by our pharmacist, doing sort of single disease management. It's transitions of care, supporting post-discharge efforts. Another body of work is our quality programs, central gap closure, helping to close gaps, chart abstraction, going after it once the gap is closed so that we can report it back to help our performance and our quality metrics with our payers. It's RAF education and optimization. We've got RAF educators. They're assigned to practices. So these teams, population health and quality teams, exist today. They are the legacy teams. When we look at the roadmap in 2025 in a few slides from now, we're going to talk about how we're going to grow those and expand those. I will say that I think some of these VBCI assets have historically been remote, telephonic. You might not have seen those. As we lean into 2025 and where we'd love to see this go, we would love to see that framed a little differently. We'd like to see them embedded and partnering with you arm in arm at the clinical care delivery level, right? So that you really feel and see the network resources, VBCI resources, the resources that are connecting you with, patients and helping to optimize care delivery. We really want to see that embedded and meshed in your clinic. So maybe today it isn't. We are working hard to get out there and see all of the provider offices and talk about how do we mesh this together in the future. I want to call to attention one other area that's really kind of a newer area for us, and that's what we call healthy communities. Healthy communities is kind of broken into two groups of work: accountable communities and medical neighborhood. Medical neighborhoods is where we're partnering with our SNFs, our hospice agencies, our IRFs, our inpatient rehabs, our home health agencies, all of these folks that are also delivering care where we need to be connecting the dots. That's medical neighborhoods. So we have a team that's focused on that. We have a team that's also focused on accountable communities. So how do we transfer some of the health of our communities and the accountability back to our actual communities, right? How are we linking what's happening with our community-based organizations to the care that we deliver? There's a lot of efforts across many health systems to do this, and we're working hard to think about how do we become a leader in this space. So that's kind of some of the pieces and parts that exist today. The next slide I'm going to show you is, this is really a great visual of what we were leaning into for 2025. And it's really kind of expanding maybe a smaller core set of services that were previously offered to a bigger enhanced set of services. And I am going to show you a roadmap of how we think we're going to get all this done. But what I like to call out is really kind of three big bodies of work that will help you support all of these value-based efforts. So how do you do all this? We believe it's really three bodies of work. It's clinical operations. So those team members that are probably in your clinics, whether it be working on quality or managing populations of people or specialty programs. We'd love to see some nice specialty programs in the future. We want to be able to integrate those clinical programs with behavioral health, nutrition support. That's a common one that's often asked. So really the clinical operations, really optimizing that And what I always like to say is it's a team. Sometimes folks don't love to hear the team-based model of care, but it's really a team that helps support you as the provider so that the burden isn't all on the provider, right? How do we leverage some other team members to help carry that work, whether it be a nurse care manager, a pharmacist, a health coach, um, a community health worker, right? Out and about in the community addressing our social determinants of health, or sometimes some of the barriers that get in the way of us achieving our health goals. So that clinical operations is one body of work that you're really going to feel in your clinics. Again, when we think about this slide, this is leaning into what we really are envisioning in 2025. The next body is tech and analytics. So a very robust analytics platform, digital health, technology that helps bring all of this, along with the performance of how you're doing from a network perspective, to life for you every day, right? So it's us really thinking about how do we give you a tool, technology and tools that bring this all to life so you have an understanding of how you're performing, an understanding of which patients might need us most, right? And then we divide that work based on what those analytics tell us. So really leaning into 2025, some tech and analytics that will help drive our work and empower us to do better in managing our populations. And then the final body of work that we're really leaning into in 2025 is how do we really become a thought leader with other organizations or even at the state level to drive and impact policy. I think one that comes to mind often that I've had several conversations with some of the providers is around Medicaid. You know, some of our toughest, managing some of our toughest populations fall into that Medicaid bucket. How do we partner with our state Medicaid partners to do policy enhancements, some benefit enhancements, really managing our populations, thinking about what we could do differently. So when we say thought leadership, it doesn't always mean internally, but externally driving policy, engaging at a broader level, at a national level, pulling best practices, bringing those back to cone. So really helping to drive, how can we make value-based care better and more effective to drive better outcomes for our populations? So these are some of where we'd love to see us lean in 2025. I've tried to give you a good picture of kind of what it looks like today and where we'd love to see our teams grow and kind of move forward. So let's pause. I think I always get asked, hey, what is the VBCI up to? What are y'all doing, right? I don't know that we get enough of that. So I want to give you a flavor of some of the things that we've been working on. I think I could give you a big laundry list, but what I'm trying to do is really hit some high level points. So some critical things that we believe happened in 2024 that we really think call attention, kind of like these are some big wins. We really started to align work across the system and the network, right? So how do we bring teams together, break down some silos, and really reduce duplication, but get you some good care management, population health services, bringing all these together so we can divide and conquer the work instead of everybody kind of working in their own little silos. So we did that in August of this year, really moved teams together under single leadership structure. We helped transition from a time when upstream was offering some services to singular services. So now when we think about services, we love to think that they all come through the VBCI, where we can help direct and sort of do air traffic control when we think about those analytics and help guide the work, right? Make sure that we've got it in the right work queues and we're teeing up the right members so that the beneficiaries that need us most get us. We did stand up a central transitions of care team. We've got 10 FTEs that are waking up every day and focused on high risk transitions of care. Our goal is, as we come out and meet provider groups, is to offer, hey, would you like VBCI to do your transitions care? Or do you have that, right? So really having great conversations to know what levers do you want to pull in the VBCI, and transitions of care is one thing that we can offer. The next thing from a system perspective at Cone, we have reduced the referral pathways. So there is a singular pathway into VBCI for services. Even if you're not in Cone and you're a provider, you absolutely have a singular way to get referrals to us. We can send out this deck and I'll attach at the end the referral pathway. So if you'd like to make a referral for services, you're in the clinic and wanting a pharmacist, a nurse, a social worker, a care guide to do some air traffic control. We have a singular way for you to be able to make a referral for all of those services. So sort of one-stop shopping. We also launched a quality design session this year. So late this fall, we really took a look at all of the pieces that we do around gap closure. How do we connect that back to you all? How do you all work with us, right? What are some things that we do that aren't great? What are all the lists we work on? So really trying to optimize and transform how our quality work might be different. And we are just starting that journey. And I think getting some very nice wins on that. One of the things that I think is really exciting is that creation of a master staff list. So this really leans into where are all the team members when we talk about nurses and social workers and pharmacists and quality team members, all the pieces and parts that connect to all of you in the provider offices. Who are they? Where are they? Where are they assigned? The effort to really understand that and know where everyone is and are they assigned appropriately? That's the effort we're really going through now. We're going to talk about that in the next slide. But do we have good plans? How do you, if you want to know who that is, how do you have access to that? So we've created what we call the master staff list, and it gives us visibility into understanding where are all the broad resources? What is everyone doing? And then, of course, another big win that I think has been a big, nice seller for us is really standard work processes. So as we think about standard scalable programs, ensuring that we can support providers with standard programs, we've got that underway. So we've got standards of work to really ensure that we are being able to solidify strong programs for you and that we replicate it, right? So that what we do for one patient, we can rinse and repeat, so to speak. So the three bodies of work that sit in sort of that clinical shop, I'm going to give you a breakdown real quickly, high level. I don't want to go into too many details, but I want to call out some major wins. What are we working on right now? We have done an exercise that I think is super interesting that I wanted to share with all of you regarding staff mapping. So, do we have enough resources to take care of all the patients, our high-risk patients, our moderate risk, right? Addressing social drivers of health. We've done an exercise where we've taken all of the network attribution, where are all the lives that all of your patients are, where do they sit? What is their chronic condition, right? Risk and list, how sick are they? We've matched that up with their SDI or social index score that CDC gives. And so we have a really good idea of what is their poverty level. So we've got that along with their chronic conditions, along with where they attributed. So what provider offices do they go to? We use all that data to tell us, do we have enough people, right? Do we have enough nurses to help you manage your most complex patients? Do we have enough pharmacists to manage your disease management to help you support that? Do we have enough social workers for all of our social needs? So we have now that data mapping to tell us, here's what your patient population at THN really looks like. And we're going through the exercise now to understand, do we have enough people to help you do all this work? And so I think we will lean into in 2025, getting enough resources, right? Right sizing that. It will probably be a big ask to make sure that we have all the right team members in place to give you the care that you need to be able to do all this work. It will take us time to get that, but we're just now really getting that great data to tell us, hey, here's where you need more help. Here's where, we can ensure that we've got the right resources. The other big win that I want to call out is clinical care pathways. So our population health teams should be using evidence-based medicine. It should be best in class, so that if you have a heart failure patient, we can say, hey, here are all the things we're going to do as a nurse care manager to ensure that as we support you with this patient, here's what you can expect from us. So those clinical care pathways are being vetted now. We will take those to really the provider SMEs, you all, to help us say yes or no, this is what we would expect for you from a care management perspective or pharmacy perspective. Again, that kind of aligns with some of the work that we're doing with Ryzen. We'll talk about that in a later slide, but those are some two big wins that I really want to call out from a population health perspective. From a quality perspective, I think it would be remiss if I didn't say we are heads down from a quality perspective, ensuring that we are meeting our year-end push with quality metrics. So when we think about a network, we think about our contracts with our payers, we want to make sure that you all are meeting your quality performance metrics. That's the year-end push of, hey, did we get all those mammograms done? Who's got it done, but we need to get it reported. Those are the efforts that quality team is heads down right now. And I will say diligently working to ensure that we wrap that up successfully. The other area I'd call out in quality is really around our design session. How can we better manage this work? Really opportunities to make us more efficient in process and give you a better quality experience. So we are working on giving a good report out from that design session and what are our next steps and quick wins. Okay, from Healthy Communities perspective, these are some of the work we've got done. What I would love to call out is I think we've done an amazing job at really solidifying our Find Help resource. So one of the amazing things I think we've got going for us and all of our patients is we have two strong resources related to social drivers or SDOH needs. So we've got NC Care 360, which is the tool that's been launched specifically for North Carolina. And we continue to work on that tool along with Find Help, which is another national tool. So two tools that we are able to utilize to get the resources, the community resources that we need for our patients. And that's really critical when we think about barriers in achieving our goals. Often it is those SDOH things that are in the way of us even achieving a clinical goal because we've got to reduce all the SDOH. So a lot of movement happening in that space. Okay, I just shared with you, here's kind of what we've been working on. I wanted to give you a good picture of these are the things we've gotten done that we feel really, really strongly that have been good and will set us up with a good foundation for 2025. So the next 3 slides I will share are very busy, but for each of those bodies of work, we've really wanted to be able to say, here's a good roadmap of everything we're working on. Each body of work in VBCI, as we think about how we ensure success with our providers, has a roadmap. So we're going to look at that roadmap briefly. They are quite busy, but what I want to do is give you a snippet of all the good things that are happening in the quarters to come. So you can see we've really broken each of these bodies of work down to sort of 5 key areas: kind of governance and leadership. How are we connecting, the governance and leadership of this work, the structure and staffing, technology and data, functions and work process, that's really operations, and integration and care redesign. So for each of the areas, we've got quarterly maps of, hey, we're working on this in quarter run, right? So as I mentioned, for population health, we need to determine our pop health teams. We need to know how many more FTEs we need. We might need to reassign what we have today. How do we ensure that we've got, if here's what we've got today, how do we even ensure we've got it assigned to the right places and make sure that everybody's got coverage? Then we'll expand and build. So really kind of thinking in a quarterly fashion to build out this work. You'll see a ton of emphasis as we look at the slides on the work that we're doing with Ryzen around data and technology. So how do we really lean into that? I think we're trying to explore what are the best options when we think about, working with our providers, managing total cost of care, managing performance. We need easy tools to engage with all of you. We have a lot of those tools today. Can they be optimized? Do we need a different tool? Those are the conversations that we've really worked on in 2024 to be able to set us up in 25 on a good roadmap. So I don't want to burden you with having to look at all of these, but you can see we've really flushed out what does this look like. Behind each of sort of these milestones live many, many tactics. So what are the 10 tactics that have to happen to achieve one milestone? It's often a lot of work behind the scenes, but really we like to roll it up to a nice visual, or what are the core milestones that we need to work on to build this out fully. So I gave you kind of a snippet because I don't want to go into the burden of looking at each of those, but I really wanted to give you a good picture of, we've got this mapped out in a roadmap for 2025 that will help think about how do we connect it all back to you when we think about true care delivery, and you all are at the point of care. Okay, I've given you kind of what have we worked on in 24. We've got you can see detailed roadmaps for 25, lots of work happening around building out the teams, ensuring we've got the right tools and analytics to come back and be great partners with our providers and really embed this work at the point of care. I want to kind of shift gears and say, how do we do this all now that Ryzen's in the picture? What does that mean? You know, well, how do we leverage them and what they're bringing? So I'm going to pivot and kind of pause from sharing specifically, the lens of VBCI, and really thinking about Ryzen and what this means at that level. So I think we love to sort of share this visual. What does Ryzen bring to the table, right? This is kind of the key the three key areas that I think are quick and ways to think about what Ryzen brings to our table. They bring clinical and operational expertise. They have some, great success in driving value-based care. They have evidence-based medicine, some tools we're going to talk about. So they bring that piece and are excited to share that. Technology and tools, again, they kind of work together with those clinical and operational expertise, but some phenomenal tools that I'm going to share, and you all will get exposed to, and I think be pulled into some work streams as we think about lifting this across the network. And then, of course, financial support. So as we think about a lot of these community programs, connection, right? Community-based organizations, tools that we need to be successful in value-based care, they're going to bring some dollars to help us do all of this work. So clinical expertise, tools and technology, and some dollars to help us get all this done. Because when we think about what we just shared and what all we need to build and how we'll build the analytics and technology, I'm sure you can imagine the cost that will come with as we think about how big programs and launching this at scale. So as we think about the things they can bring, we really break it into sort of 10 work streams. And they include the VBCI pieces and parts in those work streams. So all of this, I offer this, is done really with the providers arm in arm. So you will see some physician names, but really, as we build out the work streams, many of the conversations we've had with Dr. Hodges, with Julie Minnick, as we do this work together with Ryzen, it's really, who are the physician leaders, who are the physicians, who are the providers that we can tap to engage in this? And again, one of the, I think, great things about Ryzen and the partnership is they're very interested in doing this with the independent lens. That's intriguing to them. They really want to think about, okay, how do we be successful in this space? So much of this work is with that lens and that notion that, yes, we absolutely want to figure it out in that space. So let's go through some of these work streams. I want to be mindful of time, but I want to give you a good picture of some of the work streams that are specifically coming from Ryzen. And those are the first three work streams that you see on your screen. Care without delay, value-based care guides, and ambient listening. Let me give you just a quick snippet of each of those. And I'm actually going to start at the bottom. Ambient listening is a tool that helps bring your note, your words, your visit right into a note. I think some of the providers across the network may already be using ambient listening. We are looking at how do we expand that? How do we scale that? So I started ambient listening because it's probably the easier one to describe. And again, it's listening to your visit and putting it in a note, and boom, right there, your documentation is done. The second one, I'm just going to move up one, is value-based care guidelines. This is evidence-based medicine. I liken it to the tool Up to Date. It is evidence-based medicine that they pop right into your EMR, and it gives you not only medication recommendations, but diagnostic recommendations. All the lab orders that you might want. So it really says, hey, this patient has this chronic condition, and here's stage 1 recommendations, medications, labs. It guides you and gives you those order sets and helps you not forget, hey, here's what we need to do first. Here's what we need to do second. Here's how you treat this. The goal of this is really to optimize care, and so that we are sending just what our specialists need to get at the specialist level. It's really, not inundating them with, hey, they don't need to see this. You can do these pieces in primary care, and here's what goes to specialty. Again, each of these areas will have work streams where providers are on the work streams, and you all are participating in guiding this work. So these work streams are just now being stood up, but absolutely providers engaged in those to help build and frame out what that looks like. And then all the way at the top is care without delay. Care without delay is a 21-step, and I always pause after I say that, 21-step process to ensure successful transitions of care. It is supporting transitions of care from the time a patient walks into the hospital to post-discharge. And it's what are all the 21 things that they believe need to happen to ensure successful transitions of care. It is truly in the hospitals. And again, that work stream will be stood up with providers, but really helping to transform how we think about care delivery at the bedside and navigating patients through, the hospital setting. Again, I do think it'll be critical for that lens of a primary care specialist to bring to that work stream. So certainly providers will be involved in that. Now, some of the other work streams you see on the screen: population health care model, that is VBCI work predominantly. So thinking about those clinical operational programs I described earlier, that's a work stream around that. The next one down is the technical support. What are the analytics and the technology that need to go with population health services and programs? I'm going to look at the next slide. 2 work streams related to Health Team Advantage. How do we integrate our payer, right? So when we think about value-based care and really enhancing that and ensuring we're looking at it from an integrated healthcare delivery system as we think about our network and optimizing that, our partnership and arrangements with Health Team Advantage. Network management. How do we ensure and support optimal operations within our network? So a work stream dedicated to that. Primary care transformation, specialty engagement. This is really about what do the team model of care look like? How do we ensure that we can help transform primary care, and with you all at the arm doing that? Specialty engagement. How do we think about engaging our specialists? How do we use those that work stream to really enhance integration between specialists and primary care? So again, many of these work streams are built with the providers, right? As we think about doing this with you. And then that final blue box, Community Hub, that is a tool and some processes to help ensure that we are addressing social drivers of health in a systematic way. So let's say, are there CMS criteria for addressing SDOH? We know that they have recommendations on which screening tools. And do we have a tool and an engine that kind of feeds that tool and has community-based organizations attached at the backside? Find Help and Unitas do a little bit of that, but Community Hub has a self-service functionality. So maybe our patients would want to go and do their own screening on SDOH. We could tee that Community Hub up for them. They could answer questions and get help without even involving the providers or the offices. So it's a phenomenal tool, Community Hub, that Risent brings to the table. And I apologize because that one's kind of out of order. That is a Risent tool that they are bringing. So those first three on the first page, and then this Community Hub, which would be a phenomenal tool for our patients. Okay. So now what? We just went through a lot of content in about 35 minutes. We've kind of covered, here's what we've been working on in 24. We still have a lot of work to get done in 25, really working with you all to build this infrastructure. And then here's some tools and technology and some, expertise that Risent wants to bring, really partnering with our provider network to ensure that that's successful. So as we lean into kind of all of that, as we've been working with some of our Risent friends, they shared a thought with us. And I was like, I love that. So I'm going to share it as I kind of wrap up, these discussions. How do we sort of shift our mindset from really kind of what is legacy value-based care mindset to sort of this mature, where I think the network, when I think about where THN is really striving to go, it's really this mature focus on value-based care. So how do we really think about outpatient management of our preventable conditions, chronic disease, slowing disease progression, reducing the cost of care, reducing hospitalization rates, right? That's really where we want to head. So I offer all those thoughts and really say, I think we are leaning hard into that mature focus. That is where the network is striving to go. I want to make sure I leave time to have some discussion and put some questions in the chat. So I'm going to stop sharing and really hand it back over to Dr. Hodges or Julie. Thoughts you want to offer as we kind of go through all that and feedback?
I will just add that I am just continuously super excited about the work that's getting done in our partnership with our VBCI counterparts in support of our network. I mean, keep in mind that all of this work is occurring to truly support our practices and our ACU, and just really launching and building out a comprehensive clinically integrated network to a degree that we've not done before, as I understand it in the history. So we love our partnership with Danielle, with Janet, with the entire team. They're doing a phenomenal job. We see it every day. And I really I'm excited you're sharing all this with our doctors, because no one can describe it as well as you, Danielle. So we appreciate your partnership. And I don't know if Beth has anything to add, but we will take questions. If you guys want to throw some things in the chat, or just break in and ask your questions.
Please do. While we're getting some questions in the chat, I'm going to go ahead and please put a plug in to everybody to please, if you haven't done your RAF pretest, please do it, preferably by the 20th, especially if you're an independent doc, because I'm counting on you guys. I do not want to wash Dr. Murray's car in January. It's cold in January. So please, independent docs, please do your RAF pretests. And you employed docs can do it too, but you count on her team, so. But that information is very important for us to be able to judge where to roll out and at what level we need to roll out RAF education in the next year. And I want to make your time worthwhile and focus on the areas of RAF where there are gaps. So that's the reason for the test. And it should not take more than 15, 20 minutes for you to do. And there are some raffle prizes associated with it as well.
So we do have a question in the Q&A, and I'm going to read it, and I may take the first stab at answering the first part, and then I would defer back to Dr. Hodges and Danielle on anything they want to add. So what are a few positive and, if any, negative ways this initiative will affect a typical average specialist or primary care doctor, workflow, compensation, etc.? So what I would initially say is, keeping in mind, well, I'm sorry, I'm going to have one of you all answer because I'm now going to cough. Beth, can you take that for a second?
And I'm sorry, I can't see this question. Can somebody read it to me? Because I didn't get to hear.
I think it was a private message to Julie because I don't have it in our chat either.
Okay.
I can see
Oh, I
it in
can
the
see it.
Q&A.
I can see
I
it in
can-
the
I can-
Q&A.
It's in the Q&A, yeah.
Oh, I'm sorry, I
Doc-
didn't. see it in there.
Dr. Nita said, what are a few positive and, if any, negative ways this initiative will affect a typical average specialist or primary care doc? Workflow, compensation, etc.
Okay. There's a lot to unpack in that. Remember that, so basically, VBCI is going to help THN provide wraparound care for your patients, whether you're a specialist or a PCP. It's, it's all those frustrating things that we deal with as a doc. If a perfect world, I would tell Mrs. Smith to do XYZ, she'd go do it, she'd get better, we'd all be happy. Well, and the reality is Mrs. Miss Smith has issues. She doesn't have transportation. She has a husband who insists that she cook meat every night, and so she doesn't know how to manage to please him and still cook for her own health issues. I mean, there are so many different ways. Maybe she doesn't understand her medications, or the fact that 3 different doctors are giving her medications and they don't all know about each other's scripts and they're causing problems. So all those things that we can't be responsible for as docs in our office, but we need help of a team to wrap around Mrs. Smith and get her the help that she needs with her pharmacist, with her medication reconciliation, get transportation, all those things. So it will make your satisfaction with practicing medicine greater because your patients will actually have a shot at being able to do what you ask them to do. Maybe Mrs. Smith just needs education on why she should do what Dr. Nita wants her to do, and so sometimes just a separate voice of explaining things can be helpful. In terms of shared savings, there's certainly, if we can provide the best quality care for the lowest price, then our contracts reward us for that, and that money flows downhill. And much of the work does have to be done by PCPs, but there are certainly ways for specialists to be engaged, be involved, and to benefit from a financial way, but also remember you get those services. And the specialists also get the benefit of being in the network, which allows them not to have to file MIPS, which is expensive to do, annoying, and a burden to docs. And MACRA pays much better historically, and there's no extra paperwork with MACRA. So that's an extra benefit that the specialists get. And the specialists can also do projects that not only together make this all better. Dr. Eniola has a message in the chat. She says she is excited about VBCI investment in closing care gaps. The biggest issue we have is with closing the diabetic eye screening for retinopathy care gap. Is there anything to put in place to help with this particular care gap? Yes, there is, Dr. Eniola. VBCI has a retinal camera. And so we can come, I believe you're with the Cone Health Internal Medicine residency. We can bring our camera to your clinic on certain days, and you can sign patients up that can't get to the eye doctor, and we can try. And 95% of the time, we can get a photo. About 5% of the time, if there's bad cataracts or something, we can't get the photo, but a lot of times we can. We can also help your patients if we can't get a photo. We can help them sign up for an eye care visit, And if it's a transportation issue, we can help with those things. Danielle, did I answer that correctly?
Yes, we do have eye camera or eye clinics, and we are one of the things that we've got tasked in our 2025 roadmap is how do we make that more efficient, right? How do we get those out? Are there opportunities where we can train clinics? So lots of brainstorming to optimize the eye clinics. And I think we've heard it's been not a small, but we need to grow that. So I love that you ask about it because yes, we've got this on our map of, hey, we need to solve for how we make this more accessible to our providers.
And I apologize, Dr. Ennial is with the family medicine residency program. Sorry.
The other thing I would add to that is we are, as a network, looking at where we can expand our ophthalmology network so that primary care physicians have ophthalmologists who will take their patients to do those particular exams as needed. So we do know by looking at our out-of-net data, just as from a network perspective, that ophthalmology is one of our biggest challenges on out-of-net. And so just know that it's probably a multi-pronged approach to the support around that particular care gap. But Karen and I will be hyper-focused on ophthalmologists who will support our primary care doctors more. And then also looking at where that connectivity needs to lie. If they do see your patient, how do we make sure you immediately get that report, that kind of thing. So do know we're looking at this from multiple angles and know that that is a challenge. And it is nationally of how we figure out how to do that.
So Eve Knapp makes the point that this closes a care gap, but is not comprehensive eye care. They need exams for screening for glaucoma, et cetera. So actually, the retinal cameras are so amazing, they can pick up glaucoma. It's shocking. You're right in that it is a snapshot, and a real eye exam is more like a movie or a video. So, you might miss something with the photo, but the photos not only pick up retinopathy, they pick up macular degeneration, they can pick up changes associated with glaucoma. And really, I have a camera in my practice, and we use the camera preferentially for people who can't or won't go to the eye doctor because many exist and there's limited access in Randolph County. Obviously, a comprehensive eye exam is better, but a lot of your diabetics are just not going to do it. And so some care is better than none. And if we can do an eye photo and identify a problem, then the patient's more willing to go get it taken care of rather than just going because they're convinced there's nothing wrong until the day they wake up blind. And that's a reality. Any other questions?
I think we have a new question in the Q&A. Are there thoughts to ultimately enforce certain clinical availability, i.e. time to follow-up, time to new patients for primary care or specialty? So there may be several answers to this question, and I want to make sure I understand your question thoroughly first. So if you're asking, hey, I am a part of this primary care network, and now I'm going to be expected to make available access to our patients just as a ACO network. Yes, we need to have network. We need to have access as primary care group. We also have to have our specialists have access to the network. That is part of being a clinically integrated network, is ensuring that our patients can access care. Will we have contract criteria from a THN perspective of the expectations around that? We have not looked at that yet because ideally, if we really work to have a comprehensive network and all the right providers in it, and we've created the right standard workflows, and we've got the VBCI support, we can start to break down the gaps and barriers that we have right now on patients getting access to care in a timely manner. And we do know that that also is an issue that we are trying to address in a few specialty areas within our network. So I think You can give me a thumbs up if I kind of address that from the perspective of how you were asking that, and if not, we can expand it a little further. Or you can speak up, because I think we don't have you all muted. I think you all can speak if you want to.
So Dr. Hatcher has asked if we could comment on the 21-step discharge process.
I can absolutely comment on that. And I just took a screenshot of the core areas because to go through the 21 steps, I'm going to throw it in the chat so that you all can see the core areas. So the 21 steps fall in sort of these 3 buckets, or these 5 buckets, excuse me. Leadership, and that means hospital leadership to address barriers when we have issues moving a patient through the hospital. ED support. So the moment a patient arrives, are we beginning to look at their appropriateness for admission or not to be appropriate, and what would the plan be? So it's literally assessing a patient as soon as they get in, not just from the physician level, but from care management, utilization management. It's the actual inpatient admission. So the 3rd bucket is hospital CWD, which means care without delay. And that is interdisciplinary huddles, right? So is everybody talking and moving the patient through the transitions of care? It's real alignment around the admission. It's transitions CWD, which is, do we have good support programs to pass the patient off to? So if we've got them in the hospital, do we have a plan to hand them off, right? And then operational standards. Hey, how do we know how we're performing? Do we have good metrics? Do the leaders see those metrics? If we aren't doing good on care without delay, do we have tools to tell us we aren't doing good on these steps? So it's really operational standards and like protocols, right? Workflows, all of those things. So that's a high level, kind of the buckets that the 21 steps fall in. I will tell you the most of the steps are ER steps, things that they require us to do when a patient's in the ER, and then actual hospital pieces and parts. Like, do we have utilization management running 7 days a week? Do we have care management running 7 days a week? Are we doing huddles 7 days a week? What are we doing to migrate patients through their admission? So it's those pieces and parts, Dr. Hatcher, that really help support movement through the hospital.
Thank you, Danielle. We're really excited about Care Without Delay program and hearing more about it. So any other questions, docs? I know we're at almost the top of the hour. Everyone's hungry. They need to see their kids, their significant others. And as always, we are always here to help answer questions. You don't have to wait for a meeting. If you've got intuitive questions, if you have concerns, if you're excited, it doesn't matter. We're available always, Dr. Hodges and I, the physician liaison team, Danielle and her team, to support you and to support your practices. So don't be shy. We're excited about working with everyone. I hope everyone has a phenomenal holiday and spends time with their family and does some self-care. Dr. Cagle reminded us earlier today how important self-care was, so I intend to take her up on that for a few days next week, and I hope some of you all do too. Thanks to all the physicians who work on holidays to ensure that we can take off and others can take off. Looks like someone has a question. Yes, Jerry.
Hi, Dr. Nita had a question in the question and answer. I just
Oh,
wanted to make sure
awesome.
that wasn't missed.
Will VBCI support postgraduate efforts? We are working to bring lifestyle medicine residency to Cone Health. How will this be viewed by VBCI?
Yeah, I think we will welcome it, Dr. Nita. I think about our community programs and accountable communities and medical neighborhood and out working. I think absolutely we would support that, right?
Mhm.
I think it makes logical sense.
Absolutely. It's an exciting new field.
Yep.
All right. Well, thank you, everybody. And, as always, Julie, myself, and also Danielle are all available at any time for questions. Please feel free to reach out, email, carrier pigeon, telephone, whatever works for you. Thank you for joining us tonight. Happy holidays. Merry Christmas. Happy New Year. And we will see you soon. And do your RAF pretest, please. Good night.